I think fundamentally as human beings, we all seek and value and enjoy human connection at some level. Human connection with a trusted friend or parent or colleague brings many of the benefits that you could not find in a piece of technology, even as technology is increasingly able to substitute for human functions. Primary care has that very basic human essence to it. A trusted friend with whom to walk through the stages of life, or a trusted guide. But it is also true that convenience has its value. Time is money for people. Convenience is worth something to people, and it can substitute for what otherwise people might value. So I think that we need to have our eyes wide open in terms of how can primary care adapt to this ever-changing world of technology and artificial intelligence. We cannot possibly believe that primary care should stay exactly where it was in the 1960s with home visits and long visits and this historic sense of what that relationship was.
That's Zuri Song, a primary care doctor and health policy researcher at Harvard Medical School, introducing two themes I wish we could talk about forever: the centrality of trust and relationships to primary care, and how technology may be shifting who and what people trust in the first place. Some of this shift may simply be pragmatic. Some 100 million Americans face barriers to accessing primary care, and there are ways technology might fill some of those gaps. But I think Zuri's also hinting at a much broader sociocultural change that's far harder to track. And that's a shift in the very expectation that one should have a trusted doctor in the first place. This first hit home for me when I was reporting on concierge medicine, and I was trying hard to figure out how many practices were offering real primary care and how many were instead tapping into demand for treatments that traditional primary care wouldn't offer. Things like peptide infusions or high-dose vitamins given IV. In the end, I couldn't answer that question, at least not numerically. But in my quest, I came across an essay in GQ that I haven't been able to get out of my mind. The essay, by Rosecrans Baldwin, is called "Why is Everyone on Steroids Now?" And in it, Baldwin describes how performance-enhancing drugs, which were once limited to illicit use among elite athletes, have now become extremely popular among average gym goers. Baldwin addresses several factors fueling this rise, including the trend toward body optimization and the related impulse to post pictures and videos of yourself looking extremely fit online. But that's not why I remembered the essay. What stayed with me, instead, is the way Baldwin described the erosion of society's trust in medicine and how that breakdown has contributed to this trend. As Baldwin writes, the gap between our society's embrace of once taboo ideas and its faith in institutional medicine is widening. And personally, I laugh anytime I catch a drug commercial telling me to consult my doctor, because who the hell has a doctor anymore? Who the hell has a doctor anymore? That question stayed in my head for many months as I thought about primary care. Not just as a signal that people are having trouble accessing care, which of course they are, but also as a reminder that people, maybe especially young people, may be growing less likely to look to a doctor as a trusted source of expertise in the first place. So why is this happening? Is it the allure of online influencers, the ease and convenience of AI, or simply that fewer people are now exposed to the kinds of broad-spectrum family medicine physicians you'll hear a bit from today? I'm not sure these questions can be answered, at least not in one episode. But as we consider the stakes of continuing to underinvest in primary care, I do think it's worth asking, will the notion of having a trusted, long-standing doctor become obsolete? Or will the relational aspects of medicine, and particularly primary care, become even more important? I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Though there are a range of less traditional sources of medical information, two that we talk about a lot are AI, which we'll get to later, and human, but online, health and wellness influencers. There's a lot of understandable skepticism about these social media celebrities. Partly it's a sense that influencer credibility may have less to do with expertise than characteristics like attractiveness or charisma on video. More than anything, though, I think there's widespread concern that people are giving harmful medical advice. But there's a ton of heterogeneity among so-called influencers, and I think a hasty dismissal of their reach misses the opportunity to learn why people may be seeking these more parasocial relationships. So I reached out to Emily Oster, an economist at Brown University and an author of several books on pregnancy and parenting. Emily's built a huge online following based on the promise of data-driven pregnancy and parenting advice. Not surprisingly, her approach has generated controversy. Not everyone's wild about people getting health advice from an economist, and among other controversial moments, Emily generated a lot of pushback in the medical community when she questioned the strict limits on alcohol intake during pregnancy. But Emily wouldn't have such a vast following if she hadn't tapped into something that people want. And so I was curious about how Emily's own experiences with our healthcare system shaped her approach to communicating medical information. Here's Emily talking about her own pregnancy.
Experience of being pregnant was very different in some ways than I expected. I mean, pregnancy is always a surprise, but the experience of the interactions with the medical system weren't always what I expected. And in particular, I didn't feel like I was given the full set of choices or like I understood why something was being recommended. And the origin of my first book, Expecting Better, was really that frustration, that feeling of, you've told me not to do these 47 things. I want to understand why. Or you've told me to get this kind of prenatal testing. I want to understand why. And for me, because my training is in data, my answers to those were about, let's see what the data says and let me try to put that inside a framework that emphasizes data and some kind of risk-benefit trade-off, and then use that to inform the choices I was making. So maybe a little bit of frustration with the medical system and also just a love of asking why.
When I asked Emily how her economics training plays into her approach to health advice, she talked about trade-offs, as most economists do, but also about the values people bring to weighing any given set of choices.
I did a bunch of work on diet once, and I asked a bunch of doctors about what was a good snack. So I did a survey of primary care doctors in which I asked them what's a good snack you'd recommend to your patients? And one of the things that really stood out to me is more than one person recommended raw green beans. And I thought, first of all, that does not sound like a good snack, even as a person who invests heavily in their cardiovascular health. But also, I think it illustrated to me, and a lot of the answers were like that sort of the reason that people are struggling with their health is not that they don't know that you would recommend raw green beans, that your doctor would say that, but they don't want raw green beans. That's not a good snack. And I think there's a kind of thinking about how we organize the many different trade-offs people are making. And this is where I think that sort of economics can be kind of helpful in sort of framing, people are trading off risks and benefits. And sometimes they are making that trade-off in a way that is different than if their only goal was to optimize cardiovascular health. And in many of the things that there's a sort of pivot there into a lot of the stuff I think about in parenting, where I sort of try to think about, different people are kind of optimizing for different things or facing different constraints or thinking about different goals. And as a result, different people are going to make different choices that could be the right choice for them, even if they weren't the right choice for everybody. And both from the standpoint of evaluating what our friends are doing and not being judgmental, but also in a different way from the standpoint of medicine. I think sometimes it's worth stepping back and asking, is this what this person's trying to do? Or are they trying to accomplish something else? And, is there some way in which I can help them, maybe better accomplish that? Since I think at the end of the day, many people do want to be healthier. The question is just, where does that fit in the hierarchy of things they're also trying to get done every day?
I, of course, understand why people want to balance any given medical recommendation with what matters to them in the rest of their lives. But what's become so clear to me in talking to primary care doctors is that integrating their patients' values and preferences into their patients' medical needs is in some ways the essence of what primary care doctors do. When you heard Renee Critchlow a few episodes back talking about her patient who was in heart failure and who didn't want to be admitted to the hospital because he feared losing his ranch, it was up to Renee to come up with a suitable alternative. And what moved me so much about the story was how her patient trusted her to work outside the system's norms to meet his needs. But what engenders that kind of trust in the first place? I suspect it's different for everyone, but I was curious about Emily's relationship to her own doctors.
So when I was pregnant with my first kid, I did not have a great relationship with my doctor. It wasn't the right fit. When I had a second kid, actually, we had moved. I had a different provider. That was a much better fit for a bunch of different reasons. So I've had sort of good sides there. I think right now I have kind of the perfect shared decision-making doctor relationship because my primary care doctor is someone who I really respect, who is a friend, but she does not always agree with me. And so the other day, for example, we had like a long conversation about whether I should have a colonoscopy or whether I should have the poop in a box option. And she was basically pitching the colonoscopy. And, no one wants a colonoscopy, but like we sort of talked about it together. I thought about it. Anyway, I decided she was right. In the end, there are times in which I will push back and times in which I won't. And I think that all of these conversations are better if there is respect in both directions. And that's the piece that has always been very helpful.
Why do you think you respect and trust her? I mean, is it just because you know her well because she's a friend?
No, I think it's because she is willing to engage with things and not just tell me like, well, I'm right because I'm the doctor. So an example is, this is like so in the weeds, but I had like a blood test which showed some elevated liver enzyme. And she was like, I want you to have like a liver ultrasound. And I was like, look, here's all these papers about how like the reason this is elevated is because I did a really big workout the previous day. And like this is also elevated if your muscles are breaking down. And like I ran, the following like tempo run. And she was like, okay, fine. You're right. I'm not that concerned. But then she was like, look, you're going anyway for a mammogram, for an ultrasound for your dense breasts. Could you please just have them do the ultrasound and it will make me feel better? And if you do that, then I will never mention this again. And I was like, fine. And so I feel like there's a sort of coming together of someone telling you, like, I respect your opinion and here's how I'm coming into it. That is really important. At least for me, that's like sort of key to that relationship.
Part of this coming together, this trust, is about the sharing of knowledge and the weighing of trade-offs, especially if you're an economist. But listening to Emily, I sensed, more fundamentally, that her doctor made her feel cared for, even when Emily disagreed with her doctor's recommendations. And it reminded me of something the vaccine anthropologist Heidi Larson told me during the pandemic when I was interviewing her about vaccine hesitancy. And what Larson said to me was, people don't care what you know until they know that you care. So when we think about why people may seek medical advice from non-traditional authorities, I think we probably pay way too much attention to correcting misinformation and way too little attention to what a healthcare system engineered to support caring relationships might actually look like. Emily Hill is a family physician in rural Maine, now doing a fellowship in palliative care. And one thing Emily talked about was the difference between primary care as envisioned by large health systems and primary care as is often practiced in rural America.
Some of the talk I've heard about when people are looking for their first job out of residency is that they ask these questions from some of these health systems that they're being, interviewed by for jobs. And a lot of it comes down to, can you check all of these boxes in this amount of time? I've heard of larger health systems taking all of the PCP outpatient docs on a 2-day efficiency retreat to try to make them more efficient so that they can do all of these screenings. I think I have been surprised by the meaning I have found in this work. And I think particularly in rural medicine, there is a lot of meaning because the patient population is easy to help because they need so much help. And they have a lot of needs that some of which are easier to meet, like handing out a food bag, giving someone Suboxone for their, opiate use disorder, or just freezing their warts. That's easy stuff that also brings joy to the day.
I've always worried about the pursuit of efficiency in medicine. You can see why, for instance, it might be hard for primary care doctors to offer compelling nutrition advice in a 15-minute visit when they're up against 3-hour podcasts on protein maxing. In other words, if I were in their shoes, I'm sure I'd be recommending green beans too. But while certain types of content and behavior are rewarded by our social media algorithms, that doesn't mean people no longer need the quiet, often inefficient, behind the scenes work that so often defines primary care. Here's Emily Hill again describing a diabetic patient of hers, often dismissed as non-compliant, when it turns out she just doesn't have enough electricity to power a fridge and consistently store her insulin.
There's a patient I met early on in my training. All throughout her chart, I was pre-charting on her, it was noted that she was non-compliant with her diabetic regimen of insulin. She had out-of-control diabetes for years and years and years. So I go into the room and I meet this woman, and she's a large body habitus. She's using a walker. She's a little disheveled appearing. And I get talking to her, and she doesn't have refrigeration for her insulin because she lives in a trailer on a plot of land that doesn't have electricity. And once a month, she gets a generator and she gets enough gas in the gas tank in the generator to run the generator. She fires up her freezer and she puts a bunch of stuff in the freezer to refrigerate and freeze, hopefully, over the whatever amount of time she can run the generator for. And that's how she lives her life. She does drive an old beater truck to her appointments. I don't know how, but she lives about almost an hour away from the clinic northwest of here. And that was my first real wake-up call to realizing that these patients have a very special set of needs. I ended up calling the town hall to ask if she could store her insulin in the refrigerator at the town office, because that's what kind of things can happen in Maine too. But it's still a problem, and it's one that the system can't solve for her.
There are obviously lots of problems our healthcare system can't solve, including poverty. And that's one reason people still depend upon physicians like Emily for creative workarounds. But as you're about to hear from Bob Wachter, we may be heading toward a 2-tiered system where the wealthy pay extra to have actual human primary care doctors, and the less wealthy get care that's more AI-enabled. Bob is chair of medicine at University of California, San Francisco, as well as the author, most recently, of A Giant Leap: How AI is Transforming Healthcare and What That Means for Our Future. Before our interview, I read an advanced copy of the book, which, as you'll hear us discuss, raises some really interesting questions about the trustworthiness of AI in the clinical setting. But first, here's Bob describing this 2-tiered system he believes might evolve as AI embeds itself into the clinical landscape.
Patients pay a lot of money, and what they get is a doctor who has actually a little bit of time to see them, talk to them, and deal with their problems as a human being. I think the future is likely to be that for your basic needs, your basic medical care, your lipid management, your hypertension management, you will probably see something that is AI-enabled. Maybe AI with a doctor, maybe AI with a non-physician clinician. The analogy here is that if your needs aren't that great and you don't have that much money, you probably do your travel by yourself and you probably do your taxes by yourself. But there are still travel agents and there are still accountants for people that have greater needs or greater means. And I think we're probably going to toe up to a 2-tiered system.
Part of what's interesting about this prediction, of course, is that in mentioning the rise of concierge medicine, Bob's also acknowledging the value the wealthy place on having relationships with primary care physicians. But for those who can't afford this type of relationship, the adequacy of AI as a substitute will depend on a lot of factors, including its reliability as a clinical decision support tool. In that sense, physicians are in some ways the beta testers. So I asked Bob how he's using AI in his own practice. He described a patient of his in her 90s with a history of pulmonary embolism, admitted to his hospitalist service with GI bleeding and a deep vein thrombosis. And Bob noted how AI had already begun to replace the need to depend on specialist expertise.
In the old days, I would have searched you out for a curbside consult. And so here I am like an idiot, like running around the hospital. Can I find Lisa? Maybe she's in the cafeteria. I mean, I do this as a hospitalist. I do this all the time. I tell my team, like, I know where the ID people like to hang out. Let's go down there and see if we can find them. The idea of having in your pocket essentially a curbside consult that may not be quite as good as and as nuanced as running into your favorite consultant in the hallway, but is pretty darn good and is better than me. But there's never been a tool that you can put in full cases where you can say, this is a 95-year-old woman who has a DVT and a history of a PE, but a recent GI bleed, and she's on this and that. Any of the old tools would break. They're good at, here's a single question, what is the right dose of Eliquis for a patient with pulmonary embolism? I think culturally, I remember when Google first came out and, I'd be in a room with a patient. You probably had this too, where it was like, you knew you didn't know the answer, but you didn't want to show the patient you were looking it up in their presence. Excuse me, I just got a page. Like, BS, I made that up. I'd go out of the hallway and Google it. I think these days we have to fess up that we don't know everything, and that the use of these tools doesn't make you less of a physician. It makes you more of a physician, I think.
Bob also gave a corollary example to highlight where the act of doctoring seems to far exceed AI's current capabilities.
It was a woman with a history of breast cancer who came in with difficulty walking upstairs at home and trying to figure out what was going on. Ended up getting an MRI of her spine and went down to the radiology department. And it was while I was in the throes of writing the book. So I'm sitting there thinking, well, radiologist, are you toast? How's your 401k? You have a few more years before this thing takes over. And I sat there with the radiologist for 10 minutes in a dark room and watching, and he was understanding, and I was transmitting the clinical history and the context, watching him toggle through 5 old films, some of which were CAT scans, some of which were MRIs, some were a year ago, some were 4 months ago, in order to come to the conclusion that she did have leptomeningeal spread. Demonstrated to me that this is harder than it looks. And one of the Mayo neuroradiologists said, I can teach a 16-year-old to drive a car in a day. I cannot teach a 16-year-old to do neuroradiology in a day. And I thought this was striking to me. But in some ways more important, I think what you're getting at is then I had to come back, take this finding, describe it to the husband and the patient, talk to the oncologists, the neurosurgeons, the radiation oncologists, the case manager, to come up with an integrated plan, discuss it with the patient and family, hear what their thoughts were, organize the home care and the follow-up radiation therapy. The idea that a robot, an AI, even with sort of advanced agentic powers of being able to do stuff, is going to be able to pull this off, orchestrate this, and do the human part of it, meaning the conversation with the patient and family. Never's a long time, but in the next 3 to 5 years, I don't think so. And to me, politically, that feeling was reassuring. The unmet needs in healthcare are so vast that the ability of our problems to be solved just by doctors and nurses, or by our usual go-to move in healthcare, which is to hire more humans, to hire a human scribe, to hire more case managers and nurse practitioners and coordinators. Not only can we not afford it, we can't find the humans anymore. So I don't think this is going to compromise physician jobs for the foreseeable future. Radiology 20 years from now, who knows? Maybe. But for the foreseeable future, I think the same thing is true of nursing. If I was working in a healthcare call center, a billing department, obviously if I was a human scribe, I think those folks are in trouble. I think there are going to be fewer of them. But for the professionals, the credentialed professionals in healthcare, I actually think the jobs are pretty safe and actually will be made far better because the AI will preferentially take off our plates a lot of the stuff that makes our lives impossible.
Speaking of unmet needs, let's talk about primary care. So just start by telling us right now what's happening with AI in primary care.
There are a whole lot of companies that have seen the quote opportunity, and I'll put air quotes on that because it's hard stuff, but have recognized that the primary care system is massively broken. I've tried to find a primary care doctor in San Francisco, nearly impossible. Everybody knows that primary care is incredibly important. Everybody knows that it's broken. Part of what makes it broken is the amount of paperwork, and that's all the documentation, the prior auths, and all that kind of stuff. The EHR inbox has created, yet another intrusion on any time you left the hospital. Now you have to deal with not only finishing your notes, but now dealing with 50 inbox messages that patients give you through the portal. So I think these companies and the investors are very good at seeing a market opportunity, an area where it's important, people care, there's money kind of around. Primary care doctors, at least in some iterations of health policy, are gatekeepers to the entire healthcare system, but the current system isn't working. So they saw opportunity there. The problem is that the opportunity exists partly because the thing is so broken structurally that just throwing in some fancy AI does not fix things. If primary care doctors are underpaid, if trying to see a patient in 12 minutes who has 9 problems and is on 15 meds is impossible, it's still pretty impossible even with some fancy AI. And so the history over the last 5 years is a bunch of companies have tried to tackle primary care through a number of different angles. Some of the huge players like Walgreens and CVS have brought primary care startups. Walmart tried to develop their own primary care clinics. Amazon developed a primary care version. All of them have pretty much failed. There was one company called Forward that I helped advise, obviously not particularly well, that had a vision of being an AI-first primary care office. It was a little sparkly for me. You came into the office and it kind of looked like an Apple store, and the receptionist, asked you if you wanted still or sparkling. It was that kind of thing. It was, a little fluffy. But, really they built their own very fancy electronic health record, had a state-of-the-art body scanner, all this stuff. And they moved on from not only developing a new office, but then developing this thing called a care pod, where you came into the thing the size of a home office and there was no human around, and the AI asked you a bunch of questions and a little drawer popped open and out popped your COVID kit. And it was like, wow, this is pretty cool, pretty space age. The CEO called me about a year ago and I said, wow, the company's going public and I'm going to be a bazillionaire. He said, we're going out of business tomorrow.
Yikes.
Oh, that's not the call I expected to get.
There are probably lots of reasons these companies aren't succeeding, but when it comes to this question of trust and the role of AI in primary care's future, it's critical to recognize that so much of good primary care falls outside the bounds of what an algorithm can provide. It's one thing to say we're going to use AI to automate some basic protocol-driven tasks, like scheduling mammograms and colonoscopies, or maybe even treating an uncomplicated UTI. But when you speak to primary care physicians, and particularly those who practice broad-spectrum primary care, you quickly realize how much they do that's so far beyond AI's current reach. Rachel Criswell is a family physician in Skowhegan, Maine. Here she is describing the scope of her practice, as well as the creativity it requires.
I think the hard thing and the great thing about family medicine and rural family medicine in particular, we're pretty isolated and often we're the last stop, right? So like the specialists refer back to us if people are having some sort of crisis that relates somewhere in their body or health, they come to us. And so one of the things I really like about being a generalist is that there's like always up to date, there's always protocols that I can follow. But I think that my family medicine training kind of like taught me a way of thinking in the same way that like a liberal arts college does, to try to like problem solve and not just think about the physiology, but like, is this person going to be able to take this medicine 3 times a day, or affordability or transportation or whatever, whatever that weird thing is about that one situation. I think the thing I really like about family medicine in this case, as opposed to like other specialties, is that we also have a little bit of the surgical training. And so I've gotten to be like much more creative about procedures than I ever thought I would be. I know that sounds a little bit scary, someone being creative with procedures, but if you know the basics of like working on the skin or working in the uterus, then it kind of allows you to problem solve in a way that maybe being in a place with an easier access to specialists might not be. I've diagnosed and managed giant cell arteritis by myself twice now, including one like entire hospital course of a patient being worked up for it. I have another patient who has a tooth that I think is just about ready to come out, but no dentist will touch her because she's on a blood thinner and has a mechanical heart valve. So in combination with my colleagues, we figured out a way to sort of safely do that. I've done some like difficult polyp removals for gyne procedures. I've learned how to do colposcopy, and I do that up now in northern Maine. I like moonlight up there because there's not another provider to do that up there. I learned how to do vasectomies because the doctor I took over for used to do them and she's now retired. So we wanted to make sure that we were continuing that service. I had a really interesting case recently with a patient with a stroke of sort of unknown etiology that it wasn't like a typical sort of like embolic ischemic clot. And as I was sort of puzzling through her case, I reached out to a friend from medical school, from the Bassett program, who's a vascular neurologist now in Boston. And he looked at the report and was like, oh, this is actually really weird and interesting. So we got her set up with him down in Boston and like are now co-managing that together, which is kind of cool.
Of course, one could argue that AI could figure out the tough neurological case or tell someone how to manage giant cell arteritis. And maybe that's true or will be true. But so much of what makes primary care good and trustworthy is having a doctor who knows when to follow an algorithm and who also knows when to set the algorithm aside. A lot of patients aren't necessarily looking to doctors to follow guidelines. They're looking instead for the doctor to apply what they know to them. Sometimes that means they won't do anything a specialist recommends until they know what their PCP thinks. And sometimes that means they don't want to see a specialist in the first place. Here's Rachel describing this challenge for a patient reluctant to undergo coronary angiography.
Well, I had a patient who, it was an older lady. She was coming in for like fatigue and sort of these nonspecific symptoms. We did a stress test just kind of to cross it off the list, I guess. And it came back wildly positive. And I called her and told her, like, we need to get you to a hospital. You need to get into an ER and get cathed. And I remember she wanted like a specific appointment with me to like talk about why she had to make the 2.5 hour drive down to Portland. That's our major referral center. And like just go through everything step by step. And, could we get it done here? She really didn't want to go down there. Her husband didn't like to drive at night. And so, what I ended up doing to try to smooth the process was like call down to the ED, let them know she was coming, call to the cardiologist on call, let them know that she was coming, and try to make it as easy for her to get the care that she needed.
Of course, one can have a trusted doctor and also AI-enabled care. They are certainly not mutually exclusive. But whether AI's integration into our clinical workflows increases or erodes trust will probably depend a lot upon how we regulate it. So I asked Bob to tell us how he's thinking about AI regulation.
I spent a lot of time trying to crack the code of what does the regulatory landscape look like to get this right. And I think Michelle Mello, who's a law professor at Stanford who studies healthcare, gave me the best answer, which is basically a version of we have no freaking idea. I mean, we really have not made any real progress in thinking through what does the ecosystem need to look like to get the regulatory environment right for a number of reasons. The FDA is good, or at least in its old version, at figuring out whether this X-ray machine or echocardiogram or medication works, is safe and effective. It's never had to evaluate a tool that could be different next week than it was this week. I mean, amoxicillin doesn't change next week to what you approve this week. They've never had to evaluate tools that are not designed to handle one particular disease state, but cut across the spectrum. The same version of a tool may be doing chart reviews, scribing, decision support, suggesting diagnoses. They've never evaluated a tool whose utility and safety is at least partly dependent on how it gets implemented within a healthcare system. And Rob Califf, the former FDA commissioner, said to me, a huge part of this is really not what the manufacturer has put out there. It's how it's being used at UCSF. And therefore, the regulatory environment has to look at what is the system that you have within your healthcare organization to monitor this tool, and not just on day one, but on day 365, because your patient population will have changed. The information, maybe the science has changed. So I ended up thinking very hard about this, talking to a lot of very smart people, feeling like we're just in the earliest innings of trying to understand the regulatory environment here. David Blumenthal's suggestion, I think in the New England Journal, that we begin to think about certifying some of these tools the way we think about certifying doctors is, I think, pretty clever. I don't know that that's exactly the right answer. I was chair of the American Board of Internal Medicine. I can't tell you that every physician in the United States loves the way that we certify and recertify doctors, that is the gold standard. But I can't tell you that we have a relatively rigorous process of taking this thing we call a layperson and making sure that we have transformed them into a human being that now has a certain kind of knowledge, skills, and attitudes that is consistent with what we think of as a safe, effective physician. And AI is in some ways more similar to that than certifying that an MRI scanner or a new chemotherapy is safe and effective. So I think there's a lot that needs to happen. I think a lot of it is going to have to be the system to certify that the healthcare organizations that are implementing this stuff have the structures and the governance to get it right.
The proposal Bob referred to regulate clinical general artificial intelligence, similarly to how we regulate and license physicians, was written by David Blumenthal and Bakul Patel and published in NEJM AI in 2024. And I definitely agree it's worth reading. But I also wanted to revisit Bob's conversations with former head of the FDA, Rob Califf, who expressed concerns about administrative AI tools. Noting that AI has no soul, Califf, as Bob described in his book, worries that if AI was optimized to profit the health systems, then patients might get hurt in the process. So I asked Bob what he thought about Califf's concerns.
I think it's very smart and right in a way. Here's where I think the rubber meets the road. I think that what we're doing now, that I think within a year or two, every doctor is going to expect to have a digital scribe. Every doctor will be using AI to write their prior auths. Of course, the insurance companies will be using their AI to reject the prior auths, and we'll have this ludicrous arms race. Every, 1 out of 5 patient charts is longer than Moby Dick. So every doctor will expect to have an AI chart summarization tool. To me, these are training wheels. To me, these are the low-hanging fruit to get at some of the administrative crap that we all have to deal with and make our jobs doable. They don't get at the fundamental big questions. The big questions are cost, quality, trade-offs, and you don't get at that until you really get to clinical decision support. So to me, we're taking baby steps, everybody getting comfortable with technology and weighing risks and benefits, up to the point where the AI will help and maybe start making some crucial decisions about, do we get an MRI and do I prescribe Wegovy and do we, do this cell therapy that's costs $100,000 and prolongs life for 6 months. Embedded in those decisions are some incredibly human questions of cost, quality, trade-offs. Do I give my patient this fancy new Alzheimer's drug that maybe slows things down for 3 to 6 months at a cost of $50,000 or $100,000 and has a small risk of brain bleeding? There's no answer to that question. And humans sort of make those trade-offs. Once the AI becomes our mode of decision support, then the question is who's controlling the dials becomes very important. And you could easily see the AI telling me to use therapy A for this patient with good insurance and use therapy B that's cheaper for this patient with bad insurance, and 100 other versions of that.
So what does any of this mean for our professional values, which are critical for maintaining patients' trust?
I think Rob's completely legitimate. His worries about that are very well founded. I don't know how to get at that. I think in some ways there are versions of problems that we currently have where there may be tensions between what physicians think in terms of the Hippocratic Oath part of their lives and what the system needs in terms of financial viability. But what AI does will be put it on steroids, mechanize it, standardize it, and create a level of non-transparency. Meaning the AI is just going to say, here's the thing you should do, here's what I recommend. And you may not know what the underlying corporate values are, or maybe even conflicts of interest that are embedded in that answer. So that's a very long way of saying I worry about the same thing, how to fix it, how to mitigate it. Obviously, there's some piece of transparency that's going to be important there, but it's such a deep, hard problem that I actually don't know. And I think you're right to point it out as, I think, a more subtle piece of the regulatory picture. It's in the end of the day, that may turn out to be the most important thing, is how do we make sure that the human values we want to incorporate in our decisions continue to be incorporated when the physicians are being presented with a recommendation that maybe still there's a human there to endorse it and therefore maybe fight back against. But increasingly it will be, oh, okay, that sounds good. Click. Yes, I accept. The end game is a little scary because once it's embedded in your system, once it's giving you an answer, you don't know where it came from, you don't know what its underlying values are. And you could say, well, I don't trust the C-suite today to have the same underlying values that I have as a physician. They didn't take the Hippocratic Oath. They're looking at the bottom line. Yeah, but at least there's that tension between something coming out from corporate world and the physician saying, oh, I'm not comfortable with this. Once this thing is truly baked into our workflow and begins just spitting out a decision that you've learned to trust over the years, because they're generally right, the idea that it's not inconceivable that there's a slippery slope here, that those corporate values are embedded in those decisions in ways that we might find somewhat harmful to patients.
Yeah. And then there's also human nature problem, right? When you start automating things. I mean, I was reading EKGs yesterday and your voice was in my head. The temptation to just hit sign because assume that the computer is right is so big. I mean, my whole exercise in reading EKGs is basically like the voice in the back of my head, besides yours yesterday, was like, don't be lazy. Don't be lazy. Look at the EKG.
And you're trying to do something that's impossible. I mean, you're trying to basically say, I will remain vigilant for the next 20 years in this technology that gets it right 99.8% of the time. I don't know how often, as you remain vigilant with your little voice in your head, how often do you catch something that the computer got wrong?
Well, I don't want to toot my own horn, but it's something that creates a lot of anxiety in me about sort of like, who are you as a doctor? So I often change the reads. I mean, maybe just to make myself feel like a better person.
You probably saw the study 6 months ago or so that showed that test of diagnostic reasoning that the humans did at 72%, humans with the AI 76%, the AI by itself 92%, meaning that there's a possibility, not you, Lisa, because you're so good at this, but there's a possibility that when you change the readings, you screwed things up.
That was in my head too. I literally had just read that part and I was like, you think you're like being a good doctor because you're editing this read, but you're actually, statistically speaking, making it worse.
Statistically, that may very well be right.
Yeah. It's funny as you're talking. I mean, I began my career at the New England Journal writing about financial conflicts of interest. And as we talk about this, it strikes me that is there a greater conflict of interest than sort of the existential threat to your existence, right? I mean, the bias in favor of I am needed in this world is so powerful.
Yes. No, this is an egotistical conflict of interest and existential. I think you're right. And I think it's interesting. And I think that feeling you had, I think you articulated very well. I think people are going to feel like I've got to demonstrate that I have value. I periodically feel that with, when I get a consult and the consultant sort of says I need to do something different, that sometimes they're just trying to show that they're adding some value.
Oh, 100%. Think about when you are asked to review a paper or something, right? Like no reviewer says, this is I have nothing to add, right?
This is perfect. That's absolutely unassailable. No, it's never happened.
Yeah, exactly. So let me ask you one last question. I was struck at the end how you spoke about how your feelings about trust had evolved as you wrote the book. Can you talk a little bit about that? Because I think trust is sort of like the biggest issue of our time, and AI is just going to throw a whole other wrench into it. And I'm not sure how it's going to play out. So tell me a little bit about how your thinking evolved on trust.
One of the things I start the book with is this premise that AI will work in a high-stakes field like healthcare, really only to the extent that people learn to trust it, whether it's patients or clinicians or leaders or policymakers. And at the end, I came to essentially side with Gianrico, the CEO of the Mayo Clinic, when he said, I think the risk of going too slow is higher than the risk of going too fast. That part of my trust of a physician or of a healthcare organization will be predicated to some degree on where are they in their AI journey. When I hear of a physician now who says, oh, I've never tried it, I actually lose trust in them. It's like, this may not be perfect. You may choose not to use open evidence or GPT or whatever it is. Or if you're a writer, you may choose not to play around with Claude, which I find to be an amazingly good editor. But to not try it, to not be intrigued by it, by the possibilities, to even explore whether it might help you or your patients, to me, at some point begins to border on malpractice. And for a healthcare organization to have put its head in the sand and say, too scary, or have a system of governance that has to pass through, an armada of compliance people, any one of whom can just veto it. Oh, we're not going to do this because I'm worried about privacy or hacking or blah, 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 blah. I think is now wrong. I think is now the wrong decision. I'm not saying that they should jump head over heels to embrace this and replace everybody, but I think you have to be exploring this in the same way any new technology. This would be like saying when laparoscopic surgery came out or a new kind of cancer therapy came out. I'm not going to touch that because I like the old way I did things and everything's perfect. So I said, my thinking about trust has evolved from not just trust in the tools and how they work, but I would not fully trust a provider or a healthcare organization that just had its head in the sand and wasn't at least exploring, how do I make this work? There is no question in my mind that there are use cases here that will be good for patients and good for clinicians. There's also no question in my mind that there's the potential for harm. And therefore, like any new tool, any new technology, any new therapy, we need to approach it thoughtfully.
When I think about the complex challenges facing primary care, I think we have to embrace new technologies to the extent they increase convenience or provide accurate knowledge or give people a more thorough sense of the trade-offs inherent in any given medical or lifestyle decision. But when I think about the broader challenges facing society, loneliness, isolation, a sense that we're all beholden to algorithms that don't have our best interests at heart, I feel almost paradoxically optimistic that the relational core of primary care will become even more important and valued. This doesn't mean people won't turn to influencers or seek convenience and efficiency or pull out their phones while talking to us and ask why ChatGPT disagrees with everything we just said. We're all going to have to get used to these things. But I also don't think you can take the human out of humans. And my sense is that the people who have a doctor, someone who's known them and cared for them throughout their lifetime, don't want to let that relationship go. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Next up on NOS, we'll be talking about teams. Everyone says the future of primary care is teams. Maybe that's a team with an AI. Maybe it's a team with nurse practitioners. But what, amidst all this talk of teams, do we even really know about them?
Anytime somebody brings up teams, my immediate question is, what is a team to you? And the answer is always incredibly different, and I think that reflects tremendous variation. There doesn't seem to be consolidation into the optimal primary care team. There isn't really a consensus emerging.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. I'm Lisa Rosenbaum. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My article series on primary care can be found at NEJM.org, and our email is nos@nejm.org. I'd love to hear from you.